Today's first speaker is Dr. Sophia Moraz. She's a psychiatrist at McLean who oversees the care of young women who are often struggling with depression, suicidality, and trauma-related disorders. And she's here to speak to us today around traumatic situations, which may lead to trauma disorders, and also to this speak to the signs and symptoms which are most common in people who may be struggling. Dr. Moraz, over to you.
Thank you so much, Scott. I'm so happy to be here today and to share this information with everyone. So first off, I'd like you to think about this. Turn on your television, check your phone, turn on the radio, and you'll find an endless source of information on mass shootings, hurricanes, tornadoes, climate change, COVID difficulties, and on and on and on. These things dominate our headlines, and this doesn't even cover the chronic ongoing worries that people have around social, economic, political uncertainties. The reality is there's lots of opportunities, unfortunately, for people to develop trauma. So what I'd like for us to consider today is having a basic understanding of what trauma is, some of the types of trauma, what the physiology is in our responses to trauma, as well as what it looks like when we have a patient who's a child, a young adult, and to think about how we can respond in a way that promotes resilience with an understanding that the default really is resilience. So let's think about what trauma is. The definition, at least the root of the word, trauma comes from the Greek wound. And it's used interchangeably in terms of our response, whether it's to a physical or an emotional injury. And the reason that the focus is on the response is that we need to consider that the outcome in terms of trauma isn't solely dependent on the event or dependent on the individual in terms of what happens. On the one hand, something that could be traumatic for one person may not be traumatic for another. And that's dependent on what we bring into the situation in terms of our own vulnerabilities, whether those vulnerabilities may be genetic or psychological in terms of past trauma, or even the situation that we're in, as well as the time in our development that the event is occurring in. So these are the characteristics that individuals bring to the event. There's also specific characteristics of the event in terms of the frequency of the event. Is this a trauma that's happening in one singular time? Is it happening repeatedly? Is it a successive or cascading amount of trauma? For example, people who've suffered through a hurricane may have difficulties, not just during the hurricane where they've suffered great loss of property, they've unfortunately been injured and are lost loved ones, but then it's compounded with the loss of safety, the inability to have shelter in the moment, have a reliable source of food, reliable source of electricity, running and clean water. And that can further be compounded down the road with the dislocation that occurs as they have to evacuate from their homes. Not to mention the potential for separation if one family member ends up in one place and another in another area. Now, when we're looking at these things, what we're considering is this rich interplay between the individual and the event and what our bodies, our minds are designed to do. And again, we are designed to survive, we're designed to be resilient. This design means that we have built-in systems that perceive and respond to a threat even before we have time to analyze it. And this is really fortunate because we may not have time to analyze logically how to get out of this situation really quickly. We may not have time to think about getting out of the way of the moving car or running away from a lion. These are situations that require a really fast response that doesn't need higher order levels of thinking. That's the pro of this. This is what needs to happen in the immediate survival. However, physiologically, that repeated exposure means that we are over and over again exposed to this process that works in the acute state, right? There's this release of hormone, cortisol, that's specifically designed to keep us alive. It is designed to induce that fight reflex. It's designed to induce that flight reflex. It's designed to induce the freeze reflex. However, with repeated exposure that we see in trauma, you have this increase in cortisol that on the one hand creates a situation where your heart rate goes up, your blood pressure goes up, your circulation increases to make sure that your blood flow to those muscles are there to help you fight, to help you run, to help you do what you need to do in the moment. But with repeated exposure, this impacts our metabolism, our capacity to regulate our emotions, our capacity to regulate blood sugar. And that repeated exposure translates into diminishing response in terms of our immune system. So what helps us in the moment, a prolonged exposure can really impact our capacity to live long and healthy lives. Now imagine that this exposure happens very early on. And this is where trauma can really create a long-term impact. So when we're thinking about the types of trauma, not just in terms of its acute impact physiologically, but trauma can be, like we said, a singular event, could be repeated, so chronic, could also be complex, a series of various events creating a complex trauma response. Trauma could also be categorized in terms of who it's impacting. Is it an individual one, a person having an unfortunate motor vehicle accident? Could it be a group trauma where people of a particular group could be first responders, could be an ethnic or cultural group that have a shared identity, have experienced potentially a terroristic trauma. Could also be a mass trauma that includes things like Hurricane Katrina or other climate events. Now, each of these kinds of trauma, again, this is not an exhaustive list, but bring in vulnerabilities that could impact the individuals more acutely. So in the case of the individual trauma, depending on the kinds of trauma, the individual may feel more shame or guilt or have an inability to share the events with others and may be more vulnerable. In the case of group trauma, there may be a sense of a shared experience, but there might be a feeling that only members within that group may understand it, and there may be isolation away from others that are not part of the group. And in the case of mass trauma, there's an initial outpouring of support of media attention that could potentially fade away, and people are left to continue dealing with those sources of trauma. The trauma could also even be categorized in terms of the proximity that we experience this trauma. So on the one hand, it could be trauma that we've experienced directly, but also be the trauma that we experience secondarily or even vicariously by overhearing described by the person who received the trauma. Somebody who's very close to us, could be a loved one, could also be a patient or a classmate or colleague who's gone through a difficult, fearful, stressful experience, and they're describing to us, and we experience that trauma secondarily. Now, trauma can coexist in various groups. So you can have a trauma that is either man-made, right? That could be from either intentional or accidental. Intentional trauma could include things that have to do with assaults or kidnappings or murder or things that cause physical injury. Conversely, it could be accidental, for example, a flight failure or an accident, versus something that is an act of nature that we've talked about in terms of hurricane. And that difference can impact how people perceive that event as well. So when we have that interplay in terms of kinds of the trauma and what the individual brings to the table, and that individual could bring not just vulnerabilities, but could also bring sources of strength and resilience. In the case of children, this could mean having a very strong bond with an adult that creates a buffer that allows them to, even in the face of very significant adversity, to persevere and to be resilient. But without that support and with the repeated trauma, we have a setting where the individual may start to show signs of wear and tear. And that can mean everything from difficulty with sleeping, difficulty with eating, showing changes in behaviors that may be everything from having difficulty sitting in class and learning, all the way up to including engaging behaviors that are quite unsafe. And this has to do with where in development the trauma is occurring. So for very young children, what we see during the time of development when they're supposed to be acquiring these new tasks, unfortunately, there may be some regression where a child who was potty trained may start wetting the bed, may revert back to baby talk, may have a hard time sleeping alone at night. And an older child, say into adolescence, where their task is more towards more differentiation in school, you may see grade slipping. You may also see more rebellious behavior or engaging behaviors that include self-injury, that include substance use, or even risky sexual behaviors. There's this interplay again that happens between what the task of that development is and what the trauma does in terms of hijacking that system. So instead of the individual at a young age using their resources to learn, to grow and develop, unfortunately, those resources can get hijacked by the trauma. And what we see is an inability to pay attention, an inability to regulate emotions, difficulties managing impulse control, difficulty with attention, as well as difficulty with peer relationships. So frequently as a child and adolescent psychiatrist, when I'm doing an assessment as part of the team, regardless of what the initial complaint is, at some point in that assessment, we always ask about trauma, because there's a very real relationship, not just in terms of the trauma we see in PTSD, which we'll talk about in a few minutes, or acute stress disorders, in terms of disorders where it's very obvious that there's a presentation that can be linked to a traumatic event. Often people will present with depressive symptoms, substance abuse disorders, a range of disorders that may not initially be linked to trauma. And even if there's not a clear line, we do know that exposure to adverse events, a cumulative effect, leads to an increased risk of depressive disorders, an increased risk of anxiety disorders, an increased risk of substance use disorders, as well as an increase in cardiovascular disorder and increased risk of cardiovascular disorders, as well as diabetes, obesity, smoking, and immune-related disorders, such as being more prone to infections or even being more prone to inflammation-related disorders, because the trauma effect impacts all of these various systems. So when we're thinking about how to recognize trauma, we're not just considering major events like we listed above in terms of mass casualties or climate issues that are very obviously traumatic. We're thinking about what the individual themselves perceives as traumatic, because that's the key. One thing that can be traumatizing for one person may not be traumatizing for the other, and the presentation varies wildly. So if you have an individual that has had a dramatic change in functioning, that has an inability to function in terms of learning, participating in their career, participating in their relationships, and there's a marked difference that you can attribute to time, you might want to consider the impact of trauma. Failing to recognize this has significant costs in terms of what the prognosis is, in terms of people's ability to leverage their own strength to have more resilience. So finally, I'd like to think about resilience factors with you in terms of things that will increase the likelihood of somebody having a better prognosis. And again, it's important to consider that the default is resilience, that most people who are exposed to a traumatic event, that even if the event is traumatizing, that does not necessarily mean they will go on to develop a syndrome that meets a clinical threshold. That you could be exposed to something that's traumatic and have an initial trauma response that includes these changes we've talked about, but not go on to develop PTSD. And that's really important. So for those who are at risk, this is where we can intervene. People who've experienced previous instances of trauma, who already have mental health disorders, who already have been exposed to difficulties or are facing current adversity, are much more likely to experience a trauma response that is longer lasting. They are much more likely to have the experience of that system that we talked about that's meant to help keep them safe, not being able to return to baseline. So with that, I would like to end there and open it up for questions.
Thank you for mentioning many of the physical health impacts related to trauma disorders. That's one of the things, me personally, I found absolutely fascinating when I really started to dig into that. And I think it's really important that people understand that it goes way beyond kind of the typical things you would associate. So one of the questions that was brought up, and I really love this one. It seems like it's common for healthcare providers to struggle with traumatic experience that come along with providing care. Do you know if there are support programs or networks out there for professionals?
So that's an excellent question, because I've always said that just by virtue of being a healthcare giver, you're not immune or impervious to the effects of trauma, right? That we share a commonality with our patients in terms of having vulnerabilities ourselves. So the Schwartz Center actually has first aid skills-based training to help caregivers address specifically that. So there are skills-based responses that are used to help that it's not therapy, but it's actually a way of assessing in the moment what caregivers need in terms of like providing the support in real time.
Somebody reached out and asked if you'd mind repeating the definition of trauma you provided earlier.
So trauma is not simply the event, it is actually the response to the event. It is the emotional or physical response to an event that an individual experiences as life-threatening or potentially physically harmful to themselves or to loved ones.
Thank you. Someone said there's an interesting overlap between ADHD and trauma symptoms. Do you have thoughts on this?
Absolutely. So if you think about what a traumatic event does to someone, it really narrows our focus to getting us out of a very dangerous situation. And in that narrowing of the focus, it becomes near impossible to attend to other pieces of information or data around us. So somebody who's been exposed to a traumatic event may have a very hard time attending to things around them. So imagine going from a state of terror and being plopped into a classroom and being tasked with learning algebra. As a child or an adolescent, that would be very challenging. So it's not infrequent for adolescents or adults even to have difficulty concentrating, and beyond difficulty concentrating, having difficulty organizing and using executive function skills when they've had traumatic experiences. And when we think about executive functioning, it requires our ability to attend, but also to plan and prioritize. And in response to trauma, it's very hard to use that higher order skill. So it's not infrequent that people actually complain of difficulty attending to things and being able to plan and use executive function skills to the point of appearing, I would say, as if they have ADHD. And they can co-occur, but it's not uncommon for it to appear so.
Thank you. All right, next one. What is the distinction between complex trauma and chronic trauma?
So that's a very good question. So chronic trauma, an example of chronic trauma might be exposure to bullying. So in that setting, you're repeatedly exposed to instances where it's a similar event over and over again. So there's the bullying or even intimate partner violence versus complex trauma. It's a continual experience, such as the bullying or the intimate partner violence, that is compounded and repeated in different ways. So it could be you have the bullying at home, there are other events that you're being exposed to. It's a multitude of traumas that are ongoing that really don't allow for any respite in between or allows the individual to use resilience.
Thank you. Real quick, Hannah wrote in to let us know that Emotional PPE is another site that helps caregivers. So we wanted to put that out there, and thank you, Hannah. Next question, gender differences in trauma responses.
So even though men are more likely to be exposed to more violent events that could be considered traumatic, women are much more likely to develop PTSD. Women are more likely to develop trauma-related disorders and more likely to develop anxiety-related disorders in general.
Thank you. Andrew, thank you for putting this one in here. I think this is a fantastic question. Andrew works with college students. When gathering a health history, how can I phrase my questions in an open and curious way that asks about any events that they may have experienced that could have been traumatic?
So that is actually a great opening. I wouldn't mind saying exactly as you said it, that, is there any, so the way I've asked young adults is, have they experienced any instances where they felt fear, where they felt made to do something that they didn't want to do, or something happened to them that they've noticed reliving over and over again that leads to avoidance, that leads to intrusive thoughts. But I would be very specific, very general in terms of looking at that experiences that put them in situations that they've found fearful.
That's great, thank you. Can you speak for a moment to the impact of trauma on identity?
So if you, and this is where the timing is quite important. If you think about the impact of trauma on people's worldview and on people's worldview, not just in general, but in terms of how they see themselves within that world, traumatic events can really impact how they see themselves, how they see the world relative to themselves. So a traumatic event, say in somebody experiencing a civil war, for example, could impact their sense of self. That could this have happened to another group? Could this have happened because I'm part of this potential ethnicity? So it may reinforce the sense of identity if it's a shared trauma in terms of like something that's impacted the group in general, that they may feel closer together, but also feel like others outside of the group may not understand. The other thing is some trauma could also make people question their identity depending on how the trauma impacts their sense of self overall.
Thank you. Someone wrote in, I think this is a really interesting one, and I think it's really great for this audience, to say that they were recently asked to debrief a nurse that was physically assaulted in an emergency room. And this individual is asking, what trauma intervention should I have utilized within 5 to 10 minutes of this event happening? Is there anything that can be done immediately, aside, of course, connecting to this person to say the EAP and saying, hey, if you need help, reach out?
I would say first and foremost is making sure that that safety is in place, right? That before even considering debriefing, does this person feel safe? Are they in a safe place? Because it's sometimes, unfortunately, easy to go into the debriefing mode when I would be very careful in terms of debriefing, since people may not yet be ready to do that exercise. And you certainly don't want to push that debriefing before someone is available to do it. So I would say to prioritize safety first in terms of, do they feel safe to be on the unit? Do they need to be somewhere else? Do they need someone to cover for them to make sure that that primary need is being attended to? And then the debriefing can happen secondarily if the individual feels comfortable doing it, because doing it prematurely could do more harm than good.
Excellent, thank you. Someone did write in to say that the trauma history screen is a helpful self-report assessment to gather useful information. And someone else wrote in to ask if you work with any of the other scales with patients, like the ACEs, things like that.
Yeah, so on our unit, we do use the PTSD scale. We also use structured interviews, depending on the patient's presentation as well.
Thank you. Last question. How do you typically differentiate trauma from other disorders? Are there particular things we should be looking for?
So it's not uncommon for example, with people with PTSD symptoms, or especially acute stress disorder, to have depressive or anxiety disorders. So one helpful way of differentiating this is, can we identify a specific stressor that predated those symptoms? One of the criteria in the DSM to identify, the main criteria is making sure that there was a stressor that led to this syndrome. So if there is no identifiable trigger, that may be one way of initially differentiating. Is this a trauma-related disorder versus another disorder?
Excellent. All right, that's going to do it for right now. Sophia, thank you so much for being with us today. We really appreciate it.
Thank you so much, Scott.